Can you? I hope you can see the screen. Can you see the screen? Hello.
Yes, sir.
Yes, sir.
Okay.
Yes, sir.
Okay. Okay. Thank you. So biomechanics of the hip joint. Is a very important topic because hip joint is located in the lower limb, and within the host of lower limbs, the hip gives you a large range of motion. Okay. Now within this hip joint, we have two major bones. One is the femur and the other is the pelvic bone, okay, or pelvis. Okay. Now, primarily, I would refer to chapter 8 because this is the document what you have with you, the book by Nordin and Frankel, and you can briefly, it's very well presented in a short manner. The basics, as you can see, that we have the acetabulum. So acetabulum I had already discussed earlier in the general lecture, that it is the area, it's a hemispherical socket which is located within the pelvic bone. So the femur head actually rotates, is inside this acetabulum, this hemispherical socket, and forms the hip joint. Okay, so hip joint is basically results out of articulation of the femoral head of the femur with the acetabular socket of the pelvic bone. Right? Now, as we move down, you can see in the picture, typically the proximal part of the femur. Okay? So this is the femur head, the spherical femur head, which is rotating or articulating inside the acetabular cavity. Okay? And you have the various parts of the bone, which has its own name. So, as I was telling you, the acetabulum. Oops. Oops. Just a moment. Yeah. Oh my God, this is not correct. So the acetabulum I cannot mark it in the text. So please pay attention. On the PDF, it's not really possible to control the highlighting feature. So the acetabulum basically forms a ball and socket joint in form of a hip joint, and this it is essentially a cavity within the pelvic bone, which allows a large range of motion in form of rotations. Okay. The femur head, as I was telling you, is a spherical head, and it is articulating within the acetabulum. to give rise to a large range of motion. Now, as you all know, the femur, the structure of the femur, I have explained you earlier. Let me just switch on to stop this video a bit and show you the real bone. Can you see me, everybody? Can you see me? Hello?
Yes, sir.
Yes, sir.
Yes, sir.
Yes,
So
sir.
this is the femur. This is the real femur. Okay, I'm holding it in front of the camera. And this is the femur head. Okay, the spherical femur head. We call it spherical, but there may be irregularities here and there, but essentially it has a spherical shape. Okay, this is the femur head. This is the femur neck. You see why we call it neck, similar to our structure. We have a spherical head, and then it comes down to form an area which is less in cross section. So that is the neck area, and then it comes down to form the shaft. Okay. On the other hand, this is the acetabular cavity. Okay. Everybody can see that? It is a very well defined hemispherical type of cavity within which this hip is rotating. Okay. To give you large range of rotations. Right? Is it clear?
Yes,
I'm
sir.
holding it. Yeah. So if you look it very carefully into this structure of the acetabulum, there is a cutout actually. There is a cutout like a shoe. Okay. Those things you can see pictures when you visit the anatomic sites. Huge number of images are there in the anatomic site and in the lecture as well. And there is also a part which is called the labrum. Okay, so that is more on the top of the, it's on the periphery of the acetabulum. Now this is a very large bone, the pelvic bone, as well as the femur bone, which is the longest and the strongest bone in the structure. Just a moment, I have to close the door. Excuse me for a second. Hello? Yeah. So, I hope it is clear from these models, and you can see that if I hold it like this part is the greater trochanter. Okay. Now, obviously, this is a which femur, right femur or a left femur?
Left.
Yes, because this head should actually point medially, right? And if you look down, this is the distal part of the femur. So this part, the condyle, should face the front, and this part should be on the back. So obviously this is front, so this is anterior, and this should point medially. This should point medially. Okay, so this is a left femur. Now this part is the greater trochanter. This is the neck, and you can see very clearly how the area of cross section of the neck diminishes abruptly from the head, similar to our neck. Okay, and then we have the body of the femur. You can compare it with our body. So we have a head, we have a neck, and then the stocky part of our body, that's the femur shaft, right? On the back you have a protrusion, a bony protrusion, which is called the lesser trochanter. This should be on the back, but it should be slightly, it's inclined in this way so that you look from the front, you can just get to see it, the peak of the lesser trochanter may be visible slightly because it is oriented in a little oblique manner. So this is the strong part of the shaft of the femur bone, and this is the strongest and the longest bone in the whole structure. Now, another thing, when I go back to the lecture, when I'm referring to certain deformities, there is a very important thing, which is the neck shaft angle. Okay. Now, you know what is shaft? The shaft is basically this part. Okay. So if you take cross-sectional area at, say, small intervals, you can find the center of those cross-section. And if you join the center, you get an axis of the shaft. Okay. So I can define an axis of the femoral shaft. And if I take scans of these parts, say the head and neck, then I can define another axis. Okay, so one axis will go like that, the oblique manner. Another axis will go like that. Okay, so the angle between these two axes, okay, one is called the neck shaft angle. Okay, there is another thing also, the offset. So what is the horizontal distance between the center of the femur head and the axis of the humeral of the femur shaft? Okay, that is also known as that is called the offset. Okay, so these are osteological parameters which are extremely important regarding the mechanics of the joint, right? So neck shaft angle, offsets, the diameter of the femoral head, these things are important in the mechanics of the hip joint. Now let me go back to the presentation mode.
So
just a moment. Yes, you wanted to ask something?
yes, sir. I missed the offset. Could you please repeat what the offset was?
Yeah, I'll show you in the best is showing you in see the center of the femur. Just a moment. Can everybody go to the mute mode? Hello. Yeah. Can you see me by any chance? I'm not visible.
Yes, sir.
Yes, sir. We can see you.
But I can't see myself. Why is it like
We can
that?
see you, sir. Internet
Meeting
connection
on.
problem.
No. 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 Now I can see myself here. Now I will show you offset in a sketch later on. But see, you have this femur shaft, the axis of the femur shaft, and you have the center of the femur head. So if you like the horizontal distance between the femur shaft and the center of the femoral head. The center of the femoral head can be also located. Okay, the femur head, and remember the joint reaction force. The joint reaction force always passes the femoral center of the femoral head. Okay, the offset is the horizontal distance between the center of the femoral head and the axis of the shaft, femur shaft. Okay, I'll show you these osteological parameters a bit later in a sketch that will be easier for you to understand. Okay, now I will move on to the slide share mode. Wait a minute. So here you can see what I was exactly trying to tell you, that there can be three cases. One is the normal case in the middle, where the neck shaft angle is around 125 degrees. Well, the ideal is 135 degrees, 125 to 135, but anything beyond that, okay, we have two type of structures. One is varus deformity, other is valgus deformity. This is common in a sort of a host of population. So there may be some normal neck shaft angle, say around 125, 130, up to 135. But there may be also cases, as you can see here, where the neck shaft angle is less than 125 degrees. So this is called a varus case. Varus deformity, and you can also have more steeper neck shaft angle, more than 125, 130 degrees. So the femur neck, basically, or the head is more erect with respect to the femur shaft. So that is called a valgus deformity. So obviously, the joint reaction force for these three cases will be oriented in a different manner. Okay, so the relationship with the mechanics is the joint reaction force for a normal case as compared to varus or valgus deformity will be obviously different. Okay, so that you should be able to identify. Now, if we move on to, this is typically pictures of a hip joint. If we move on to now, a few words must be said about common fractures that occur. Okay. Now, particularly in the age group of older patients, you might have heard that a little fall results in a femur neck fracture. Okay, very common femur neck fracture. Okay, now femur neck fracture is just the femur neck actually dissociates from this whole integrated structure of head, neck, and shaft. Okay, so it cracks in an oblique manner through the neck. Now, that is one type of fracture. The other type of fracture is the trochanteric fracture. So there's, if you can see it, let me just show it in a rough manner. Oh God, this is difficult. So just follow the cursor. So it breaks like that, oblique manner in the trochanteric region, the greater trochanter and the lesser trochanter. So I'm moving the cursor, so it moves like it cracks in that line. Okay, so that's a trochanteric fracture. If the neck, femur neck fracture is like that. So the head neck is dissociated, is fractured from the shaft. So this will actually go, move apart from this, in that, the fracture is oriented in that manner. Okay. Now, if I move into some of the individual parts, before I move on to the individual parts, let me just summarize the movements of the hip joint. Okay, and that is important before I look into this kinematics or statics. Can everybody see? I hope. So primarily, we have 3 rotations in the hip joint. There may be slight sliding within the acetabular socket, but primarily we actually get flexion extension, very clearly exhibited here. Abduction, adduction, similar to shoulder. You raise the leg, then you have abduction. You bring it back more towards the medial side of the body. It is called adduction. So this is clearly abduction, adduction is clearly exhibited here. Then you have the external rotation and internal rotation. It is more synonymous to pronation and supination of the elbow joint. Okay, so external rotation is moving your leg outwards towards the lateral side, and moving your leg inwards is rotating your leg inwards is internal rotation. So these are the 3 main movements, primarily rotations, that is arising out of your hip joint in the lower limb segment. Okay. Now, if you consider the gait cycle, you are not all, now everybody is aware of the gait cycle. So within that gait cycle, you can see, if I try to plot joint motion in degrees for, say, flexion and extension, you can see that how during the gait cycle, how this flexion extension is the angular deflection or the of flexion and extension is varying during the gait cycle. So you have the hip joint, the firm line, you have the knee joint, a broken line, and you have the ankle joint, which is the dotted line. So if you consider the start, then of course the hip joint scores the maximum degrees of flexion. Now if you move more from stance phase to the swing phase, this angular deformation is actually less in case of, it reduces with increase in the percentage of the gait cycle, but it again increases during the swing phase and rises to around, say, 40 to 45 degrees of flexion. Okay. In case of knee joint, you can see the flexion is higher, even higher, but there is, the flexion angle differs. The nature of the flexion angle differs at the initial stance phase with the hip joint. For the ankle joint, it is also a different trend during when we are executing a normal walking cycle. Okay. So for the other motions like abduction, adduction, and internal rotation and external rotation, you can actually have these during the, as per expressed against the percentage of the gait cycle. Now, regarding the kinetics, the forces, we will have a separate, you get to know much more about the forces acting on the hip joint, particularly the muscles, the joint reaction forces that we will study in a much more elaborate manner because there is a lot of mechanics involved in it. So you will get to know about it separately. But generally, if you look at it, so very preliminary static analysis that I will discuss is the 211 page, this one, simplified free body technique of the coplanar forces. So very simplified forces, you can see here that we have from the ground reaction, we can have the force here acting through the knee joint. So this is the ground reaction force. We have the two important forces that is considered in this free body diagram is the quadricep muscle force. So the quadricep muscle force is indicated by force A. Okay, so this is basically the force A, and the joint reaction force, hip joint reaction force, which is an effect. Okay, it's a reaction force, and quadricep is a active force. Okay, muscle force are active forces, and reaction forces, joint reaction forces are passive forces, like the forces applied by the ligaments. So the joint reaction force is basically resulting out of a set of active forces acting on a particular bone or in a joint. So the quadricep muscle force is very, very important muscle force in the hip joint, and the hip joint reaction force is the force that is arising out of a set of forces. So these three, if we consider them as coplanar forces, they constitute a triangle of forces, and they try to keep the body in equilibrium. So another small problem, very elementary level. So it is a single leg stance. So the calculation box shows external forces acting on the body in equilibrium during a single legged stance. The ground reaction force is equal to the body weight. The gravitational force of the leg stance is equal to 1/6 of the body weight. And the remaining force is equal to 5/6 of the body weight. So this is, in this condition, they have solved the problem. So just look into this problem. You can get hold of very easily what are the components of the forces they have found out. Now there is the next comes the dynamics. Now regarding these dynamics, there is a small calculation shown in this book. Okay, that's in page 214. Well, you can look into this calculation, but we will consider, as you can see also in the calculation, we have this quadricep muscle forces taken as 2 times the body weight, and the joint reaction forces come as 2.7 times the body weight. Okay, so in this figure you can see very easily, but we will have a separate lecture starting next week regarding finding out in detail, because perhaps in the earlier Friday class my TA has discussed with you the principles of inverse dynamics, but there is a website and a big data file which is known as HIP98. Okay, so that HIP98 is whole data file is uploaded in the mechanics of human body folder. Okay, and there are websites which is maintained by University of Berlin. Okay, so they are sort of, that is a seat of learning, and they have been doing research on musculoskeletal system, particularly focused on the hip, for a long time. So they have a database and they have reading materials to understand what has been done. Okay, so we will discuss that separately in the next class. This class is the starting class, so the first basic idea of the structure and function, movement, and primarily the static analysis. So you can look into these calculations in the book very clearly. Now, an idea of, if I give you an idea of the hip joint reaction force. So if you look into this page number 215, you can see that how the joint reaction force of the hip varies with the percentage of the gait cycle. Okay, so the case A refers to actually the force pattern for normal men. Okay, so this is the variation of the hip joint reaction force for normal men during gait cycle. For women, it is little different. Okay, so that is the pattern B, where force pattern for normal women. Okay, and the C is, it is showing the activation of different muscles during the gait cycle. Okay, so you have the names of the different muscles, and here but remember, if you can see the abductor muscles. So what they are saying is the first peak corresponds mainly for the abductor muscles. And this is, see, the extensor and abductor muscles. So the abductor, so if you look into the hip, okay, if you look into the femur, for example, in the hip, basically the abductor muscle force, I was perhaps telling something little bit. If I look into here, first set of calculations, go back, see, this is the action of the abductor muscle. Okay, the abductor muscles are strong muscle that is trying to force the femur inside the acetabular cavity. Okay, so the action of the abductor muscle is very important during the motion, a very basic motion, like a normal walking or gait cycle. Okay, for any other motions as well, the abductor muscle always plays a very important role in the hip joint biomechanics. So the contribution of abductor muscle and, say, the joint reaction forces are always the maximum in the hip joint biomechanics. And that is the reason they have actually plotted these two in the whole simplified static analysis. I go back to that figure. Yeah. So in this figure, they are also telling the first peak corresponds mainly for the extensor and abductor muscle. Okay, so the abductor muscle, you see the extensor, flexor extensors, and the adductor. So abductor muscles are actually contributing a lot in the basic movement of any person. Now, very interesting is table 8.2. It's a range of typically reported hip joint reaction force from, say, different selective studies. The latest of which is HIP 98, but it is not too different. Okay, so you can see during walking, the peak hip joint reaction force as a function of body weight is reported. Okay. Now, for a long time, say 1966, 1967 till 1993, 1995, it is reported here in this book. But after that, the HIP 98 is the published data was in 1998. They have come up with very precise calculations and measurements together. And they have reported for about 4 types of patients during walking. Okay, during walking, the peak joint reaction force is precisely about 2.38 times the body weight. During stair climbing, this force climbs to about 2.43 to 2.45 of the body weight. Okay, so which is not too different from 2.7. You can see 2.7 here. It is saying 1.8 to 3.3. So there has been a lot of work done, but for different types of patient, this data on what is the exact ratio of the peak hip joint reaction force to your body weight will vary. The ratio will vary, but it will vary within a range. Okay, as I told you, that a varus valgus deformity within a patient can actually affect this ratio as well. The offset, the osteological parameter, plays an important role in the calculation or in the hip joint reaction forces. So therefore, there is a range which is specified. If you consider general, then there is a range which specifies the values of the value of the ratio of the hip joint reaction force to your body weight. Okay, but generally speaking, you can always consider that it is 2.5 times the body weight, the peak joint reaction force. Just if you say, if somebody asks you, it's around 2.5 times the body weight, you can say the answer. Okay, for normal walking and stair climbing, remember. This is a very important information. So 2.5 times the body weight is no joke. Okay, so if somebody has a body weight of 70 kilograms, so 2.5 times is about 210 kilograms, isn't it? And 210 kilograms is the peak force during normal walking of the hip joint reaction force. So you can easily understand the amount of forces these joints or bones are subjected to during a simple daily activity like normal walking. Okay? If you consider more demanding activities like running, jumping, this ratio can go up to 8, it can go up to 10. Say, consider a cricket player, a bowler, who is delivering a ball on a single leg. At the point of delivery of the ball, he's basically jumping a fast bowler and landing on one feet and delivering the ball with a thrust. Okay, remember the force at the hip or knee joint at that particular instant of delivery of the ball. It is huge. Okay, so these forces are extremely important for different purposes. Okay, consider an elderly patient for whom little impact, just slipping in a toilet or stumbling, falls down and immediately breaks the femur neck. Okay, it is not just the forces, it is coupled with the quality of the bone of the patient at that age. Okay, bone actually degenerates with age, and if the bone, it generally becomes more osteoporotic, so there is a shell, and inside the bone there is hardly any bony material, like the trabecular bone slowly disappears and the porosity sets in, so that reduces the strength of the bone. So it's very average type of force in form of an impact or in form of any other. Even I have heard that osteoporotic patient cannot, sustain its own body weight. Even the body weight can produce fracture in the bone. So, coupled with the degeneration of the bone quality, any force at the hip joint hip joint reaction force can be considered to be high with respect to the condition of the patient. Okay, but generally speaking, for a healthy patient, normal patient, these are the values that has been reported. But if you look into the calculations, that is exclusively from February next week, we will start the exercise of understanding the dynamic analysis based on inverse dynamics principle, and looking deep into HIP 98 and the website maintained by the University of Berlin in Germany, which contains a lot of useful data as well as principles. So we will learn a lot regarding the calculation of hip joint reaction force as well as the muscle forces when we move on to the next lecture. But this is I think most of it. You can just look into this chapter. Not much is left, only another sort of problem. Effect of external support on the hip joint reaction force. That is 219. Effect of external support on the hip joint reaction force. You can see how, somebody, a patient who needs support, okay, because his hip joint is affected by some reason or the other. Now see, raising from a low chair produces approximately 8 times the body weight. Just see here. It's a very important information. So raising from the chair needs aid. A simple aid in form of a stick. Okay. So as you try to raising from a low chair produces about 8 times the body weight in case of A. This has been measured. B, walking with a cane on the contralateral side of the affected hip. So this is the contralateral side of the affected hip. Reduces joint load substantially to 2.2 times body weight. Okay. So this is how, when somebody, why people use these aids, particularly when you are trying to stand up from a sitting position, maybe also for walking. So this actually aids you to during some problems related to your hip joint. So effect of the external support on the hip joint is shown in a simple calculation. So just have a look into this, and I think coupled with the lecture on the anatomy, physiology that I have indicated in the main conversation of the teams, coupled with this book and the lecture, I think it would be easy for you to understand the basic, the basic biomechanics of the hip joint. Now the class is open for discussion. I'm stopping the recording.